Welcome to lecture Return to Running After ACL Reconstruction. I am Major Arun, and in this session we will walk through how to bridge the gap from supervised rehabilitation to independent running safely and efficiently. Running is more than a fitness goal. It is the first real test of knee's ability to manage repeated impact, braking and load transfer. Because of that, we won't clear someone simply on the basis of time since surgery. We will use objective, multi-domain criteria that include strength, movement quality, load tolerance, and psychological readiness. Over the next sections, I will explain the physiology and biomechanics, the objective benchmarks we can use, a staged progression framework, and practical monitoring tools you can use in clinic and at home. By the end of this lecture, we will clarify the physiological and biomechanical demands of running after ACL reconstruction, so you can appreciate what tissues and systems are being stressed with each stride on gait mechanics. We will present evidence-based functional criteria used internationally to decide when to progress a patient to running. These are measurable and reproducible. You will learn practical and graded progression strategies that are criteria-led rather than calendar-led. How to move from alter G or aqua jogging to overground running and then to sport-specific drills. Finally, we will cover how to evaluate readiness and how to monitor load, symptoms and risk throughout the progression so you can safely advance or regress the program. Running is a central milestone after ACL reconstruction because it reinstates cyclical loading and coordinated deceleration tasks that the knee must tolerate. Not every patient aims for or will return to pivoting sports, but many want to resume jogging, fitness running, or field sports. And running is the stepping stone towards sprinting and cutting activities. Importantly, simply waiting a fixed number of weeks is an unreliable clearance strategy. Patient heal and recover strength at different rates. Objective functional criteria reduces guesswork. They give us quantifiable milestones such as strength symmetry, hop performance, and absence of effusion that predict safer progression. So, our approach is to move from low impact supported running to high impact sport specific running only after these benchmarks are satisfied. Why functional criteria are so important? Time alone ignores biological variation, tissue incorporation, muscle atrophy, and neuromuscular recovery differ greatly between patient to patient. Functional criteria such as measurable strength, movement quality, and symptom response force an individualized assessment that reflects real capacity to load the knee. When athletes return early with unresolved deficits, they commonly display altered mechanics such as stiff knee running, decreased knee flexion on landing, or compensatory hip strategies. These altered mechanics increase both short-term re-injury risk and long-term joint pathology. Thus, the point of functional criteria is risk reduction. They help ensure the knee can tolerate the specific demands of running before exposure is increased. Some of the risks and misconceptions before introducing running progression. A common misconception is that recreational running inevitably accelerates knee osteoarthritis. The data do not uniformly support this. In fact, some runners with established osteoarthritis report improved pain and function versus those who stop activity altogether. This means we should not blanket ban running. Rather, rehabilitation should be tailored to the individual's goals and capacity. The real risk comes from returning to running with unresolved deficits. That's when abnormal mechanics and overload happens. So, our job is to individualize, educate, and monitor rather than discourage running as a whole. Historically, clinicians often used a time threshold, commonly more than 12 weeks, as the main criteria to attempt running during the ACL rehabilitation. Over time, we have added clinical checks such as minimal or absent effusion, symmetrical hop test results, quadriceps and hamstring strength measures, full or near full range of motion, and acceptable pain levels. Limb symmetry index thresholds are commonly applied. A limb symmetric index of 80% is often a minimum, though higher is preferable for sport. The problem with these older approaches are variable definitions and inconsistent applications. However, they represent the baseline of contemporary decision making. We will refine these into evidence-based thresholds in the next slide. More recent guidance synthesizes a set of multi-domain benchmarks. First, range of motion. Flexion at least 95% of contralateral side and full terminal extension. Second, effusion. Only traces or absent intra-articular fluid because rebound swelling signals intolerance. Third, strength of quadriceps limb symmetric index should be more than 80% of basic readiness, with many authorities preferring more than 90% before faster running and sport-specific running. Fourth, pain control. The patient must be pain-free on low-impact running. Substitutes such as aqua jogging or alter G sessions. Performance tests. Eccentric impulse on counter movement jumps and repeated single leg hops tasks should meet symmetry thresholds, commonly more than 80 to 85% of limb symmetry index without pain, compensatory patterns. These combined markers afford a robust, multifaceted view of readiness. Central criteria or the central pillar, it's the so-called quadriceps. Quadriceps function is the central pillar for return to running. During running, the quadriceps provides the primary braking or eccentric to control the eccentric force at contact and controls knee extension movements in swing to stance transition. Weak or delayed quadriceps activation forces compensatory strategies, increased hip reliance, or stiff knee running that are raises the risk of re-injury. Therefore, emphasize eccentric strength training, rate of force development drills, that is fast eccentric loading, and progressive running tasks that challenge eccentric capacity. The benchmark commonly used are an isometric quadriceps limb symmetry index should be more than 80% and isokinetic symmetry approaching more than 70% before attempting sustained overground running. Hop test and functional performance, how these two are related. Hop tests assess both power and landing control. They are functional proxies of running demands. A single forward hop measures propulsion and ability to eccentrically decelerate on landing. Repeated hop tasks like pogos, triple hops add endurance and stress tolerance. Importantly, observe quality, frontal plane collapse, valgus at landing, or increased knee extension movements on injured side. These are red flags even if distance appears adequate. Many clinicians use an 85 to 90% of limb symmetry index threshold for hop symmetry, but combine this with qualitative scoring. A poor landing pattern should delay progression. Use video or slow motion review in clinical practice to capture subtle changes in technique. Progression to running is staged and incremental. Stage 0, pain-free walking with quadriceps limb symmetry index more than 80%. This confirms baseline tolerance to body weight loading. Stage 1, non-impact or reduced impact reintroduction such as aqua jogging or altered G treadmill at 70 to 80% of body weight and aim to re-establish gait pattern under reduced axial load. In stage 2, overgrown walk jog intervals, short jogging bouts of 30 to 60 seconds interspersed with walking to accumulate running volume without continuous loading. Monitor symmetry and symptoms closely. During stage 3, continuous easy running, longer continuous run at lower intensity while tracking mechanics, cadence and pain. In stage 4, sport-specific running with cutting drills, progressive increase in speed, direction and change of direction and reactive elements only reached after strong strength and movement quality markers. Each stage should include objective monitoring and only progress when predefined criteria are met.
Rehabilitation of running post ACLR follows a graded progression to ensure joint safety and efficient reloading. The sequence begins with normal walking, restoring symmetrical stride and endurance. Aqua jogging follows, where buoyancy reduces ground reaction forces while allowing near normal mechanics. Next, walk jog intervals as depicted in the table in the previous slide on treadmill introduce controlled bouts of running with recovery phases. It must be followed, as we have mentioned in the previous slide, that was the progression stages in every session. Once tolerance is achieved, progression continues to continuous jogging, emphasizing cadence, stride length, and symmetry. Finally, the patient advances to running drills on level ground with close monitoring for compensatory movements or swelling. Each step must be criteria driven, not time based, ensuring readiness before progression.
Physical readiness is necessary but not sufficient. Psychological readiness is a major determinant of successful return. The ACL Return to Sports Index questionnaire quantifies confidence and fear scores. Above about 65 correlate with higher return to sports rates. Incorporate patient reported outcome measures like International Knee Documentation Committee and ACL Return to Sports Index into reviews to identify fear or avoidance early. Address psychological barriers with graded exposures like small, supervised running exposures. Goal setting and referral to sports psychology when required. Remember, fear can alter movement and reduce effort, which undermines the physical markers we are trying to achieve. Even with good test results, load management is the safety net. Monitor objective metrics daily or weekly. Swollen knee volume, range of motion, quadricep strength, and hop test for symmetry. Use a stop modify progress rule. Stop progression if pain more than 2 out of 10 in numerical pain rating scale, or if visible effusion increases, then modify or reduce volume or intensity and reassess. Apply the FIT principle, increase frequency, intensity, time, and type gradually. Example, add 1 to 2 minutes of 5 to 10% volume per session rather than jumping suddenly. Build planned deload weeks into the program to allow adaptation and recovery. And reintegrate cross training like static bike or swimming to maintain conditioning without excess impact. To summarize, do not clear a patient to run on time alone. Use objective, multidimensional criteria that include range of motion, effusion status, quadriceps eccentric strength, hop symmetry, and movement quality. Eccentric quadriceps capacity is the central determinant because running demands braking control. Use a staged progression from low impact modalities to overground and then sport specific running. And embed frequent monitoring and psychological support. With this structured evidence driven approach, we improve the chance of a safe, confident return to running and subsequent sport. The criteria and progression I presented are drawn from recent clinical guidelines and peer-reviewed studies. Notable sources include Aspetar guidelines and recent systematic and cohort studies on return to running thresholds. Always cross-check these general guidelines with your surgeon's intraoperative findings and patient goals.
For optimal recovery, it is essential to follow the rehabilitation exercises in the demonstrated sequence, beginning each session with a structured warm up and concluding with an appropriate cool down. This systematic approach ensures that each step builds on the previous phase, promoting safe, effective, and progressive rehabilitation. Patient videos and images shown in this presentation are used with prior informed consent. Jai Hind.